All right, hello, and welcome to another Down Fracture podcast, a podcast for talking jaws. Per usual, Dr. Sam Bobek is here with me, Dr. Michael Wasson. Sam, what's up, man?
Not much. Middle of the summer. Kind of in the thick of it, huh? You're in between vacations?
Yeah, we are headed somewhere, kind of mini vacation. We're gonna go to LA, San
Nice.
Diego area for a few days here in a little bit. Go to a Dodgers game because I know you love baseball.
Ooh, Dodgers though. Come on. I got a good college friend who's really into Dodgers and or a couple of them actually. It just hurts. All they do is spend money. Um,
I
man,
mean,
they're
would you
spending a
want
lot.
that if it were your team? Isn't that what you want?
I don't know. Yeah, I mean, I guess I'm kind of prone. I grew up as a Cubs fan and now I'm a Mariners fan. So I guess I'm biased towards teams that lose. Just if they become winners, I don't know how to cheer for them. So I don't know. That does sound good, but yeah, getting to
Never.
getting to some
Never been to
sunny weather
Dodger
is nice.
Stadium. I'm gonna go. I just haven't been to Dodger Stadium. It's not that we're
I haven't
Dodgers.
either. That place looks cool though. I
Yeah,
think I'd like to see a game there.
we went to San Diego. We went to a Padres game a couple summers ago. It was cool. It's a cool stadium.
Nice.
All right. Well, what are we talking about today? We're gonna go through. Well, I guess let me back up and do my basic stuff here of downfracturepodcast@gmail.com. We didn't get any email responses last week. I was a little surprised. Well, we got
I
one,
think
I guess.
yeah, I thought we were going to stir the pot a little bit more on that one. So
Maybe, maybe people don't love us anymore.
it's all right.
Maybe.
No, I think the midline discussion we probably talked about a little bit more than people were anticipating. So there's some nuance there.
Maybe. Well, yeah, if you do have ideas, suggestions, cases, let us know. We do read them. Downfracturepodcast@gmail.com. All right. Well, today we were going to talk about nerve injuries with the sagittal split osteotomies, essentially, is what we're going for.
Yeah, I mean, I liked it. It was definitely something that came up in terms of our discussions with each other. And clarifying the sites of nerve injury is useful for learning this. It's useful for talking to patients about it. And I found it just useful in practice because what I was hoping to just narrow down the nerve injury discussion to be a direct nerve injury, like a witnessed nerve injury. Because I think we all know nerves can be injured in different ways. But the formal separation of the inferior alveolar nerve into two segments is what we're going to talk about. What do
Okay.
you think?
So, yeah, just to be clear, we're avoiding, I mean, I'll even throw, we're not talking about local anesthetic injuries, which in theory could happen. We're not talking about, hey, the patient's hypoaesthetic or paresthetic afterwards, but we didn't see anything. You're talking about you're in the middle of a sagittal split. You've now come across what you can see as separation of the inferior alveolar nerve into
Yep.
fragments, and
Yeah,
you're
like
dealing with
in
that
nerve
situation.
injuries from wisdom teeth or implant placement, you learn, or I know we both have given talks on this topic where if it's a witness nerve injury, the repair is immediate. And so I think the witness nerve injury in sagittal osteotomy is different than generally what people talk about with nerve injury after sagittal osteotomy. You think that's
Okay.
true?
Yeah. I mean, well, let's just get into it. So, I mean, we're talking about all you saying you want to kind of run through all the different ways that it could be injured or the situations that could present themselves. So we're talking about a direct injury from a saw or a burr as one, I'm
Yeah,
assuming.
so I mean, I think that the nerve can be separated, and managing that is different than your standard, oh, the nerve gets compressed, or as it advances, it changes position of the mandible, or like the hardware could be compressing to some degree. I think for me at least, the improvement on neurosensory recovery has come from separating things I can manage, right? Like a nerve injury should be managed. Like a direct nerve injury should be managed in real time. And so kind of coming up with ways to prevent them from happening, but also ways to manage it because this stuff comes up, right? I mean, you do enough sagittal osteotomies, you will definitely run into this situation. So I think it's a good one because I feel like it stresses people out, certainly stresses me out. Um, and having a management strategy for the stuff that stresses you out is probably better than letting it take over, right? Like, what do you think? You've seen these now.
Oh yeah. Yeah, I'll share a little. Do you want to hear a little story? Like, do
I
you like
love
stories?
stories. Let's do it.
So my first, and actually it's funny because you know the patient. He was in and around a number of surgeons in Seattle because the reason it's interesting is it was my first case out of residency, and it was a revision case, which for residents, young surgeons out there, I would
Bad
strongly
idea.
advocate against that scenario. But at the same time, you know, you're trying to build a practice and you can't just say no to a lot of things sometimes. And, you know, it wasn't an overly complicated case, but it was a revision of a sagittal split done by another surgeon in the greater Seattle area and had a nerve injury. So first case out of residency happened and kind of your nightmare scenario, as you're saying, because, you know, at that point in time, you know, you see things and you do things in residency. You don't have a lot of experience. You know, what's the old expression about experience? It's what you get right after you needed it, so to speak.
Yeah.
And so there is that moment in a panic, and this was pre, I want to say, I don't know, I want to say pre-Oxygen, but what I mean by that is it was certainly before my exposure to Oxygen and having allograft available.
Yeah.
I mean, it may have been around. It just wasn't in my repertoire at that time. And so there is that moment of panic of, yes, this is a revision case. Now there's a nerve injury, and I've got to advance this mandible and do some little asymmetric correction. This is not how I wanted things to go. And
Sure.
so,
Yeah, because I think in complication management, we've talked about that. I mean, it isn't that this nerve injury is happening in isolation. So we're talking conceptually about it, but in practice, it's in the middle of everything else that's stressing you out, right?
yep.
Whatever
So yeah,
else is going on. Like it's already a hard case. Like what you're describing, revision case, it's already hard. And so you're fighting scar, you're fighting just kind of like your uncertainty or experience with it. And then the unexpected happens, and now you have to manage that in the setting of everything else, right?
yeah, I mean, I think what you're getting at, or one of the things you're certainly getting at, is well, you've still in theory, I guess you don't have to. I guess you could abort if it was the first side or something. But I mean, in reality, you've still got to carry out the surgery, which may mean the nerve was already going to have some tension on it, or if you're advancing or doing some asymmetric correction, well, now how are you going to deal with that? Especially, you know, allograft can solve a lot of problems. Not always the ideal solution from a cost standpoint, or maybe even an outcome standpoint. But you know,
But
now
I
I'm trying
mean,
to advance this. What's
yeah,
that?
taking a step back and thinking about it rather than getting in the middle of management and all the rest of things. I think there's a few areas of the operation where you're more likely to have to cause a direct nerve injury than others, right?
Sure.
Um, and so I don't know, it's both me and for people I've worked with over the years. I'm sure there's other spots, but I generally think of it as like from moving down at the Hunsuck. So if your dissection isn't above, or if you intentionally have a short split, you can cut it there. That's a tough situation, by the way. So I would generally counsel people to be careful on their dissection in that area. But that's one spot. So at the Hunsuck, um, as you make the cut through the mandible on the Dalpont, the vertical cut, if you don't control your saw or your piezo or whatever you're using, you can cut it within the mandible in that location. When you split the mandible, splitting the mandible, I think, causes tearing of the nerve in certain mandible shapes. So that's definitely a spot that can have an injury. You can have an injury at the mental foramen. So the saws or instruments can slip, or just something comes up, the advancement, it's a retraction injury at the mental
Mhm.
foramen, you can have an injury. And then when you're removing interferences along the way, you can have burrs or instruments cause an injury, right? I think you can sneaky have a partial injury, you do the other side, and then torquing the mandible causes that injury to complete. But it'll be generally high at the nerve as it enters the mandible. So at the Hunsuck, somewhere in the middle of the mandible or at the mental foramen, right? So to me at least, like the times that can technically come up are those times. What do you think?
Yeah, you hit the main ones that I was going to say. Retraction was the one that I wasn't sure you were going to get to, and I think that can come into play. I mean, I think The other one that you may be missing, but maybe not as per this conversation, because you're talking about a direct witness operation and you kind of touched on it earlier about compression. But I mean, you can put the drill, putting positional screws in, or you could even try to go monocortical for your plate. You may
Sure.
not witness it, or if you drill some holes and then you move the segment and you might see it then, but you're
Yeah, certainly other ways to injure the nerve, but like from the
probably not
witness
transecting.
injury that I think you're going to be able to repair in real time,
Yeah.
it's going to be those spots. Because I mean, the repair is pretty different depending on where those things are, right? Like, I
Yeah,
mean,
trying to do it at the Hunsuck sounds like that's a nightmare.
well, I actually feel like that's the one that people have the most experience with.
You think so?
No, you think
I
it's
would
at the
I would have
Dalpont?
thought I would have thought mid body kind of coming from the inferior border cut or the vertical Dalpont. I think that would be my guess. That would have been where I would have put my money as where people see it the most.
Yeah, that I think that the location I think is important. Maybe it's just that you're not witnessing as much. Do you think that's what goes on at the Hunsuck? Like you don't
Oh yeah,
you
I
just
mean I think that absolutely can happen, where you're not sure. I mean, there's certainly times your dissection's not great or you're kind of wondering, and yeah, I mean I think if you see it up there, it's definitely less likely to be witnessed. Although I think you kind of see the nerve fall down.
yeah, that's what I mean.
Like, I think you
Because
see it.
the advancement of the mandible in many ways, like the usage of a J stripper or something to strip the medial pterygoid can help you visualize the nerve, just to ensure continuity. And I mean, obviously you don't want to formally remove the nerve from the mandible if it isn't already exposed, because that just increases the rate of numbness. But I mean, most of the time you see it to some extent, and if it falls down like that, then something's up, right?
Right.
And so I think that one's the hardest one to manage, by the way.
Up,
Just
up at the Hunsuck.
yeah.
Oh yeah. I mean, trying to repair it up there is just access wise is just such a challenge.
Yeah. So when it comes to nerve injury, how do you go about it? Like let's say those are defined ways. I would say to minimize those happening, by the way, a good dissection at Hudsuck, or if you're intentionally doing a short split, just not carrying your saw too far, or your piezo, or however you're doing it. I think that planning the osteotomies will help you out, minimize that. Controlling your saw, obviously. I don't know if there's other techniques to minimize the risk of tearing that. I think experience, this is something that gets way better with experience, by the way.
Well, I think that's where I would kind of say I feel like the most likely, or where I would have thought, if we were to poll all of our listeners, and we got all 77,000 replies, I think I would have put money on the inferior border Dalpont because I think that's the hardest because you're kind of going by feel, like you kind of really trying to lay that saw or that burr flat and get through cortex to where you kind of feel that softening. You know what I'm saying? And I think if the nerve's anywhere near there, or sometimes if you take it to the saw too lingual or the burr too lingual, you stay in cortex because you're on just staying in lingual cortex. And so I
Yeah.
think that feel has a tendency sometimes if you're doing that, you can take it too superiorly to where you're like, okay, well, I'm not feeling myself get through cortex, so I'm not through yet. And I know I have space between cortex and the nerve, and you keep going and you can get it there. Or if it's a little bit buccally positioned when you kind of transition from that inferior border cut to the buccal,
Yeah.
try to keep that buccal cut monocortical as you transition from the inferior border. Those are the areas where I think it's a little tricky.
Yeah. Cause I mean, I think the experience helps minimize the different sites. I mean, I feel like experience early on, it helps the Hudsuck the most, and then likely the mental foramen next, and then Dalpont, and then the splitting. Because the splitting of the mandible business, it's very like you have to be controlled, you have to manage suction. You don't want to put, you have the propagations going laterally and you want to turn it medially with the curved osteotome. It's important that you don't cause a nerve injury with the curved osteotome. And so management of the split, whether there's wisdom teeth, there's different anatomy, like you're saying. Um, I don't know if there's really just one fix for the inside the mandible splitting tear type of thing. I think that to me, that's kind of the one that persists no matter what. I mean, it lessens
That's
with time, but it definitely
like
is
I
still
agree with you
there.
on I agree with you 100% about the experience, and I feel like there's almost like as you get more experience, there are, my earlier in my career it was Hunsuck and inferior border where I worried about it the most, and I feel like
You mean
except
Delpon and inferior border? Or no, you worried about how
no, I
Hunsuck?
mean like you said, the Hunsuck, like
Okay,
because I
yeah,
think
yeah, yeah,
early on without experience, that dissection can get you in trouble
yeah,
sometimes.
yeah,
Like
totally.
that's not always an easy dissection with the concavity of the mandible. You're trying to pull on certain tissues, visibilities, not easy. You don't always have hands. I feel like early on that was a struggle. Now I feel like I don't struggle with that as much. Inferior border, if there's not extremes and like, wow, the nerve is really buccal or really inferior. I feel like, yeah, with experience, each of those got easier, but then completely agree with what you're saying about the splitting part. Like you've got to split the mandible, and this is where I've run into it more recently in my career is, you're most of us, I think, partially split the mandible, try to get an idea where the nerve is and free it up if needed, like if we can. But sometimes that's not easy to see or feel, or sometimes it splits faster or slower than you want it to. And so,
Totally.
like, you might be in the middle of that process, you might be doing the right thing, and then all of a sudden it splits quicker or slower, or something unusual is going on, or it looks like the nerves in the distal segment, and then right at the last minute, it kind of dives buccally, and it's at that one kind of spot, still in the proximal segment before it goes back in towards the middle foramen. I think that's where like kind of like I think you were saying that part doesn't necessarily always like that doesn't go away. Like that's just part of the procedure. And I think
Yeah.
that's the tougher, but maybe less talked about one aspect of where you can get the nerve injury.
Yeah, definitely. I mean, it's always nice to reduce the rate of having the injury in the first place. And so maybe there's a couple nuggets in there for people, but the splitting of the mandible one is definitely like just it's hard to really say all the different subtypes of mandibular anatomy, the different subtypes of age, and the subtypes of different how many times they've had surgery in the past, and whether or not teeth are in there. You know what I mean? So I think just being aware of it, the the torn nerve in the middle of this split definitely. The good news is on that one, I think that's the easiest one to manage, right? I mean, I think in terms of location, that's the easiest one
Yep.
to sort out, and so not everything's lost. One of the things I've kind of picked up as time goes on is when to manage it, right? Like so to minimize it happening in the first place is ideal, but like your story, when it happens, it's hard not want to not manage it in real time. Like what it seems to be the right thing to do is to finish up what you're doing, whether that's splitting the mandible, getting rid of interferences, just finish that up, do the other side, put them in intermediate fixation or final fixation, and then manage the injury. And almost it's almost better to get fixation on the other side first, to just like sort things out because there's the emotional part of it. There's very much like you might need some extra tools part of it, and that's going to take some time. And trying to get some wins in your column in the operation might make a lot of sense. Certainly stabilizing the distal segment is only going to help you fix the nerve. So
100%. I'm in complete agreement with you because I mean that's the other part of it is sometimes you have to figure out when you try to fix it immediately, and that's when you're in that panic. I think a lot of people do make that mistake of, oh, I just saw it, I've got to fix it now.
yeah,
Well, what if you fix it and then you put them into fixation, or you advance the distal segment and the tension causes it to tear
it's exactly
or
right.
pull out the suture that you put there, or it might affect how you want to do the fixation. Like you might have some tension that pulls the nerve up higher, closer to the superior border where you might put positional screws. So I definitely think you can make that exact mistake of trying to repair it, getting in your bubble of there's a problem, I must fix it. And
This is
getting,
totally from experience, by the way.
oh, absolutely. And then totally, I like what you said there because I think it's very true, but it's something that's not said. We talked about baseball and sports and stuff, but sometimes getting some momentum like helps you. Like sometimes you said, getting some things done, getting some wins, but like sometimes just, okay, I've got a problem. Well, I've sorted out all these other things. I've got some momentum. Instead of juggling five things, now I'm down to two. I think that mentally can help you, can also give you some time to not make your decision immediately.
Yeah.
Like you're not saying, okay, I've got to fix this problem right now. It gives you some time to kind of get through some other things, stop juggling so much, and all of a sudden, okay, now we got to sort this out and fixate this side. And then it's just sometimes a little bit easier. I would also throw out there another reason to do that is, and I've run into this before, where if you are going to use allograft, it's not always just right there, right?
Yeah.
It's in the freezer or the rep has to bring it.
Yeah.
So if you're not sure you need it or want it, it's also gives you some time to say, hey, look, I'm not sure we're going to need it, but let's get our ducks in a row. Let's call for it. Do we have it? What kind of timetable are we looking at? Because if it happened on the first side and you haven't even cut the second side, it might impact how you want to go about things. Do
I mean,
we do
I
we
generally
proceed?
think though that closing, repairing and then closing, I mean, the original problem still exists, right? Like the reason why you're doing the operation will still exist in that scenario. And then splitting the mandible secondarily after nerve injury, it's very like prone to have another nerve injury.
Oh,
Um,
absolutely.
and
And I
so
think harder because I mean, how much do you trust the position? If you're doing a revision case and it looks like you're looking at the canal, do you trust that position?
what do you
You
mean?
know what I'm saying? Like if you're
Oh,
looking
like
at,
where it is within the
yeah,
mandible? Yeah, no, I know.
if
I
that
mean,
person's already had surgery.
obviously depends on the timing of revision, but it's much more uncertain where the nerve's sitting throughout the mandible, right? Like it's we draw it out now, is in 3D. It's great to mark it, but there's still some uncertainty there. So
Yeah. So yeah, I'm with you in that. I think it's only going to get harder the second time.
yeah, so I mean, I like the idea of kind of getting the other things sorted out and then getting into the meat of the nerve injury business. I've had different attendings over the years, different kind of approaches with it. I think we both do nerve repair otherwise. And so you had mentioned in terms of nerve grafting as a possibility. And so you brought out, I think it's the only cadaver nerve available to us. Are there other cadaver nerves or is it just the one company
It's the only
actually
one I'm
making it?
aware of.
So yeah, so there's in the nerve repair world, there's some principles of nerve repair, right? Like tension-free closure, ideally having a little bit of a gap between the nerve. There's conduits now, like people who've used veins in the past, they've used autogenous nerves, um, direct suturing. I don't think you have to get into that whole detail, honestly. I think this is in a direct injury, it's more principles of surgery, right? Which is reapproximating the nerve, getting it under tension-free repair. And I think there's things you can do to the bone to free up the nerve. So I think the idea of oxygen grafting is there, which is great. That's a great option. And if you haven't done that, starting the suture outside the mouth is going to be the best way to do that. So that's a little cheat.
Yeah,
Suture in both
100%.
ends. Just put some stitches outside the mouth, by the way. It'll be way better. But anyway, but freeing up the nerve from the bone or doing things to the bone to free up the nerve, I think is more commonly the approach. You think?
Yeah, absolutely. I mean, I guess what you're getting at to make sure I'm thinking what you're thinking is sometimes you have to free it up from the mental foramen, get you a little bit less tension or access because sometimes if it happens near your Dalpont, you can not have a lot to work with. You might just have a little stub there.
Yeah, because I mean, it's it's the location of injury is important, but it's also what are we doing to the mandible? right? Like, are we correcting asymmetry? Is it a big advancement? Um, is it a setback? You know what I mean? So the location of the injury plays a role, but also what's happening to the overall distal segment is plays a big role as well.
Yeah,
So
you got to free it up if you're advancing or making an asymmetric movement to the other
because
side,
I
for sure.
because I think you can free it up within the split. So the common one that we've been talking about within the split injury, you can free up more of the nerve. You know, you don't intentionally do that typically because you want to leave the nerve within its home, but you can gain movement because the tension on the nerve, it can move up higher, right? Like, because the sag in the picture that you're showing, the curve,
Hmm.
that nerve can move more if you free it up out of bone, right? And so
Hmm.
you can get some superior movement in the nerve, get rid of some of that laxity to help free up some nerve, right? So I think freeing it up within the split can be helpful with the reciprocating saw or whatever you're going to use. I'm sorry, reciprocating rasp, or freeing it up from the metal framing. So
Yeah, so just to be clear, we're saying the same thing here, maybe for our listeners. You're saying let's say wherever the nerve is, if it's in the proximal or distal segment, most likely, hopefully, most commonly in the distal segment, you're saying even though you would normally leave it alone, unless you needed to free it up from the proximal segment, what you're saying is by releasing the nerve from the bone gives you less tension, more movement, you can then better repair it. Is that what you're getting at?
yeah, totally. I think there's freeing up because you typically just go right to the metal frame and you're like, well, I'll just, free that up and then I'll have more space. But you should have more nerve that isn't exposed within the mandible itself.
Right.
Right. So I mean, you got to watch out for teeth, obviously, but
Mhm.
I think don't forget about that part of the nerve to free up. So
For
with
sure.
that, by the way, the this might be too much in the weeds, but I do think there's importance of freeing, like when the nerve moves its position within the mandible, that there could be sharp segments lingual to the nerve. So just watching out for the compression on the backside of the nerve. But I'm probably getting too much in the weeds.
Yeah. I mean, I think that's what our listeners like, right?
I don't know. Yeah, that maybe the repair. So let's say we can tension free the nerve. So it sits passively. We can put it there. I think what you said about changing fixation is important because when you're right about to sew, you kind of already want to have figured out your interferences on proximal distal segment. And I don't know about you, but I have an impression when I seat the proximal segment that it stretches the nerve differently. And when your proximal segment is free, the nerve can have more laxity to it. And so when you seat the proximal segment, you can stretch the nerve. Does that make sense?
I'm not sure
Like
I follow you. You're saying when
in an
you're,
advancement, the seating of the proximal segment affects the soft tissues around it.
oh, yeah, yeah, yeah. And so, yeah, okay.
And
So
so
would you
making
advocate
sure
then
the nerve
for
is,
dissecting the nerve up, freeing it up higher?
yeah,
Do you
so
think that
the
would help?
nerve is passive when the proximal segment is seated, is what I'm getting
Mhm.
at. So, like I would assume you're talking about putting plate fixation in, maybe, or positional screw fixation. But like getting yourself up to the point of the fixation and maybe even to the point of having the plate on the proximal segment, and then repairing the nerve. Is that,
Yep.
yeah. So at least you don't get to the point again where you're repairing the nerve, you've freed it up, and then you see the proximal segment, and then all of a sudden you haven't freed it up enough. So
Yeah, I would advocate for, again, from experience. I tend to do exactly what you said, is I like to free it up from the bone if I need to. And then it goes back to what you said previously of try to do everything else you can before you even get to this point. Get your interferences out of the way, do the other side, like any other work you need to do, try to get everything done so that the repair is like the last thing you do before you fixate, but having a plan of how you're going to fixate. And then I tend to do kind of as you said, I tend to follow the nerve up in the soft tissue and try to actually dissect it. I take a curved hemostat or a dissector, and if I feel like I'm getting some tension, I do tend to do that as an additional step. I don't know that I recognized it as such as you said, where you're saying when I seat the proximal segment, the soft tissues around will shove that and put tension on it. I don't know that I ever thought of it in that context. I just thought of it as, hey, I really want this as loose, passive,
Yeah.
mobile as I can get it. But that's an interesting take that I don't think I'd considered that seating the
Dissecting,
segment itself would pull on it.
and that's, in big advancements and stuff, right? Like you're doing an MMA and whatever your Delpont gap's 10, 12 millimeters. And then anyway, hopefully you don't
Got
have a
one
nerve
more.
injury in that situation because it's a hard one to manage. But yeah, I mean, I think dissecting up on the nerve, I mean, does that ever cause more bleeding for you though?
Minimal.
Not bad.
Um, it is a little tough, and I worry about causing more injury
Yeah,
because
yeah,
you almost have to kind of put a little bit of like hold the nerve with a delicate forcep to have some tension on it
yeah,
and kind of, so I mean, I worry about it causing more injury, but I haven't really, the bleeding part hasn't been,
yeah.
well,
Okay.
I mean, I don't have a ton of these, but the
No,
ones I
I mean,
deal with.
because I think that's how it goes with these things is like once you get experience, you start having a lot less of these. And so then you don't have as much experience anymore, right? And so, like calling on life experience with it. Because I mean, for sure, I've seen it at every one of these locations I've talked about. And there's maybe other locations I just haven't seen yet, but um it's it's just something that comes up. And so, having a plan for it. The Dalpont cut, let's talk about that one because I feel like that's one I saw in residency for sure. Because it's just an early one. So the Dalpont, you're making your cut and there's an injury to the nerve. So that's the one that you classically free up at the mental framing, right?
I think
And
so.
are you releasing the incisive branch? You always got to do that, right?
Oh, that's a good, I'm trying to think back.
You do an 11 blade in there to release it. I mean, you kind of have to, don't you?
You mean like kind of skeletonize it from the soft tissue just so you're not pulling on that too much, or what do you mean?
Just the distal or the terminal branches of the nerve. One that moves inside the mandible to the anterior mandibular
Oh,
teeth.
okay. I see what you're saying. Yeah. I mean, I think you sometimes have to because at that fork, it just kind of becomes difficult to manage if you don't.
Yeah, I mean, I think freeing up the nerve of the mental foramen makes fixation tough, and that really slows the operation down. I mean, the repair of the nerves obviously slowing things down, but freeing up the mental foramen, I'd be a little partial to grafting before that. So, and you don't have to free it up all the way. Like if it's at the Dalpont, depending on where you put your Dalpont, all you have to do is really just remove the bone overlying the nerve
Yeah, I think,
distal to the injury site. You don't necessarily have to take it all the way to the mental foramen.
well, I think you mentioned some things earlier that are applicable to that scenario, but I think there are also things that maybe people don't all know who maybe are not as involved in the nerve repair world. But I think there's also this tendency that people want to just like smush the nerve together. Like you were saying that we've learned that having a little bit of a gap actually suits you. And then for the rationale for that, as I understand it, is if you really just kind of cram the nerve together, suture it tight together, you're kind of creating this jumble where things aren't lining up. Whereas if you kind of create a gap between the two nerve ends, not a big one, then they have a tendency to kind of heal out and branch more or join more correctly.
Yeah.
And so, yeah, you don't necessarily need to free it up. And I would even throw out, I mean, I don't know that we know the answer to this question, but since it's an IA injury and you're going to have it walled off within bone to an extent, I mean, I think if you can even just find a way to get it close, you've done a pretty good job as far as
Well, sure. I
free.
mean, I think in the Dalpont injury, for sure that's applicable. Like, let's say you're Dalpont injury and you're doing a setback, right?
Mhm.
Uh, as long as you can, create a bit of a window to see the nerve. I mean, you I kind of like to seal for helpful. I mean, you put sutures in the nerve, you try your best, 5-0, 7-6-0, 7-0, whatever you're using. But some Tisseel is helpful for that too, just to kind of help hold the nerve in place. And so, like freeing the entire distal segment up to the mental foramen, or I'm sorry, the nerve within the distal segment to the mental foramen may be overkill.
I think it is, unless you really need it for lack of tension. Because I mean, I think you have to weigh in. We've talked about all these different areas you can cause an nerve injury, and trying to free it up is certainly one of them too, right? Um,
Yeah, oh yeah, the non-direct nerve injury. I mean, I guess in theory you could you could cause another nerve injury during it.
That's what I mean. And sometimes it's not apparent. It might be a crush type injury or another type of injury that maybe you don't see it because it's not transected.
Yeah. I mean,
Uh, so you got to weigh that, I think, too. And I think if you, within the confines of the bone, if you can free up enough nerve to just get the two ends in relative close proximity, I think that's probably better than going through great lengths to do all those other things.
yeah, because I mean, generally, what's the goal here? We want to get the nerve close to allow it to heal, and then we want the bone to heal, and we don't want to come back and do any more surgery, right? So, want the patient to get better after our interventions, and so the spirit of nerve repair is very much helping the body heal itself, and so getting the nerve around each other, getting the bone so it doesn't get in the way. We can, I don't know. And I have this tendency to say, I think like everybody, where you're overthinking it a little bit, maybe causing more trouble.
Definitely.
So,
What
what
about
do
up
you,
at the Hunsuck? How are you
Hunsuck? I think you just
how are you dealing
suture.
with those?
I mean, that's hard to suture, but that seems to be the easiest in that it's easy to access. I mean, it's high, which makes it difficult for retraction and all that sort of thing. But there's a lot of excess nerve there. And so, just putting a couple of stitches in, that sort of thing.
Do you wrap those?
I mean, I think the ease of me getting wraps is that's a lot easier for me to get than actual nerve grafting. Nerve grafting is at a hospital right next to me, but it's at an orthopedic hospital. So the wraps are a little bit easier to access. And so it looks nicer with the wrap on there.
Yeah, I mean,
I mean,
for me, my philosophy is if it's out in soft tissue, I always try to wrap it, but it is difficult to get up there.
yeah,
Like putting a wrap on up there
I just
is
always
not a
find that area
given.
bleeds. And so it's like I'm always concerned about that. And the hard part, I think, generally there is just making sure you get the right two ends, right? Because there's a lot happening there, and you want to make sure you're sewing the right stuff. Because temporalis looks a lot like nerve. I know that sounds silly, but has that not popped into your head? You're not
Maybe,
thinking,
maybe,
am I, is
maybe
this?
in Seattle. I don't know. I don't know what you're doing.
Because I mean, there's fat, let's not discount the
Oh man,
fact
yeah,
that fat can join the party, and that makes everything more hard.
that's yeah. When fat gets involved, that is just terrible. I mean, that, like you said, that's just so hard to access. I mean, it's a little bit difficult within the split. So do you have any? Well, I guess let's maybe walk through it and well, do you have anything else you were going to add on that aspect of things?
The repair business.
Yeah.
I mean, I think generally speaking with this stuff, the one that we may not have mentioned, which I think if there's residents listening, with nerve injury, it's going to bleed, and that can cause panic in a lot of people to the point of wanting to clip or bovie or anything else. That bleeding will stop. You can press compression, those sort of things. The delay on the repair helps out with the bleeding business. I just wanted to make that quick point because that was something that took me a little bit of time to get comfortable with.
Yeah, maybe don't use Surgicel or something up there, but you could pack
Yeah,
it gel foam thrombin,
yeah.
Afrin.
As you're repairing, it can stir up the bleeding business, and so anyway,
Yeah.
the bleeding is definitely part of nerve repair that we can't forget about. So I don't know. That was my last little tidbit on the intra
Well, I was even going to
repair.
say just for sake of going against our normal structure here, which is usually disorganized chaos. Do you want to like kind of walk through this and give some tidbits that you have as to maybe we go through how to avoid first and then well
Well,
maybe
because I
that's
think we hit on most of those. I was going to touch on the patient part of this.
yeah, go ahead.
Like, I mean, because what you would expect with neurosensory recovery after a direct injury is different than what you would expect after your typical sagittal osteotomy, right? Because I think it's important to disclose these sort of things. I think it's important to discuss kind of what to expect on recovery because it's going to take a longer time before you would even expect to have some numbness return, right? Like
Right.
some numbness resolve, sorry. And so kind of paying attention to that side a little bit more because if you're in the middle of an otherwise busy orthodontic practice, you're not formally remembering which side on which patient was the injury, right? And so, because these things are pretty rare. I mean, I don't know if you quote a number to patients. I generally think these things are more in the order of like one in a few hundred, maybe like two, three, 400. Like it is an unusual thing to come up, kind of once you get into the meat of your practice. And so to me, like making note of it and following those patients differently, because I want to make sure they heal right. Because what isn't talked about with nerve repair enough in my mind is the fact that it can fail. Like there are revision nerve repairs. Like that's a real thing. And so, making sure people recover, because if people develop dysesthesia or if they have total numbness and it's in an area of previous nerve repair, I think sending it to a friend that does nerve repair, sending it to, or, like considering reopening things up and addressing it differently. Like the secondary repair is definitely something to consider here. So.
Definitely. I mean, would you, well, I mean, I know it's patient specific and also what the patient wants. Dysesthesia, I would certainly entertain that idea. Would you do it for just anesthesia?
Maybe. Yeah. I mean, I don't I don't leave anyone totally numb. I mean, total numbness is rare.
Okay.
That really shouldn't be an outcome you're seeing. Partial numbness happens. So like the functional sensory recovery business, um, trying to figure out the rates of numbness with sagittal osteotomy, reading that literature it's like super hard to make heads or tails of it. And so from the standpoint of nerve injury literature, witness nerve injury is going to have its best outcome of repair initially, and you would expect functional sensory recovery to return. So I think once you get them to the 6 month period, if they're still not having sensation, you got to catch them in the first year. And so floating the idea of repair again, even though that's probably going to sound terrible to everybody involved, it's a discussion that should be brought up.
Okay. Fair enough.
I don't know. I
What has been, can you speak to your personal experience as to when you've had to deal with this? Are you getting functional sensory recovery most often, commonly?
Yeah, I mean, it's definitely a delay, right? So I don't expect anything to wake up in the first month or so. And how we're kind of following things is a little bit closer than how I would typically follow nerves, because I know that's a variable in practice on testing patients on neurosensory recovery. So whether that's done immediately afterwards or 6 weeks or 6 months or not at all, there's different arguments for that. And I know that to be a practice variable depending on what surgeons you talk to. And so I don't know, in my practice at least, I'm typically following nerve injury patients a little bit closer on their recovery. So I would start testing at 3 weeks, 6 weeks, 6 months, maybe even seeing them in between 6 weeks to 6 month visit, maybe like a 3 monther. So I don't know, do you change your follow-up at all for that subgroup?
No, I mean, I haven't, luckily, knock on wood, as the kids say, I haven't had to deal with it too much.
Yeah.
I generally, I generally don't because I probably would give them the full 6 months anyways, unless they had dysesthesia. And maybe I'm wrong, but I would think I would know about the dysesthesia by usually by 6 weeks. I would expect them to have it if they're going to have it. Not always, but I would kind of expect to hear from them. Otherwise I'm just kind of presuming I would probably give this the full 6 months before I would repair it anyways. One for the nerve perspective, and also two from the bone perspective. Like I want things to heal enough to where I'm comfortable going back in there. And so I don't really change it unless I'm watching something specifically, like they are starting to get dysesthesia or it gives them peace of mind. I usually have a conversation about it, but I'd say most frequently I can't recall deviating from my follow-up.
Yeah, the good news is most people get a lot better with the repair, right? Like, I mean, even though the nuance of, keeping bone from compressing and nerve gap or no nerve gap on the repair, all that stuff that we're kind of getting into. I think generally people heal after these, and particularly young people, right? Like, because most of the orthognathic patients are going to be young, and that subgroup of people just seems to do well. And so we got that in our side. So I think dysesthesia seems to be definitely an older person type thing. Otherwise, nerve management is still true in the direct nerve injury group of patients. So
Yeah. Yeah, I mean, I could definitely think of one or two in my career where the side where we repaired did better from a functional sensory recovery standpoint than the contralateral side.
Yeah, totally. Sorry to
I,
laugh, but I
yeah.
mean that's totally the case. I mean, anyway, I think in practice, it's hard to really get a lot of reps with this stuff. So I honestly I don't know how many injuries I've had, but I mean it's been a number. I mean it's past the point of really like wrapping my arms around a number. It's just that these days it just doesn't happen that frequently anymore, which is lucky
Yeah.
at least. But that doesn't mean it still can't come up. So having a game plan for it, I think, is important.
Yeah, you got any other tidbits you throw out there to people?
I think there's likely people in your general city or in your region who have maybe more experience with nerve repair or who you send for nerve repair. Because I think what's weird about our practice is we tend to do all this different side stuff at the same time as jaw surgery. And so like us repairing nerves isn't like a crazy thing. But if you haven't done that sort of thing, like just establishing a relationship with your local nerve repair person, lady or guy or whoever they are, you know. So
Yeah. I mean, I'll throw out some other things on there, and you kind of I think we kind of hit on a couple of them, but I mean, one that I would throw out there that I sometimes feel like people don't always either realize or vocalize, and that's with the Hunsuck, with your horizontal osteotomy superiorly, you don't have to, you're not required to, residents out there, you're not required to go find the lingula and cut right there.
I remember that being a big part of resident jaw surgery.
Yeah,
Like
you
I
don't
was
have
very
to go
focused
find it.
on finding that.
Would you say?
I was very focused on that.
Yeah. Yeah, because I think that's how you're taught. And when you read the book, it's start your dissection superiorly, dissect down to the lingula and make put your retraction right there, cut just above that. But I would throw that out as a tidbit is you don't have to make your cut right at the lingula. If you don't want to be in just cortical bone where it's so thin and you're going to create a bad split, but you might do more harm going to find and dissect that out. And maybe even if you do find it, take your osteotomy a little bit more superior to that. I mean, really all you need is to be ideally distal to it and be able to create separation between the buccal and lingual aspects up there.
Yeah, I mean, I think you're right because if you dissect down to the actual lingula, the tendency, whether you're using a saw or a burr, is for the tip to tip down because you're fighting the cheek incision and the cheek retraction, and so your instrument's wanting to cut lower medially, right?
Hmm.
And that's
Yep.
not what you want from the nerve's perspective.
Well, I would also say the orientation too can throw you off because the mouth is open.
Exactly. And their
Your
head
your
position
vision
depends this. Yeah, yeah, yeah.
and you're visualizing that you're cutting horizontally, but the mouth is open. And so you're thinking
Totally.
horizontal, but it's not with relation to the occlusal plane.
Yeah.
And so I think you can create a little buffer by, usually again, when you do enough of these and you've seen enough lingual aspects of the mandible, you can kind of even tell where the lingula is going to be without finding it. You can see the curvature comes up to support that, and like you kind of get where that concavity is, and you can go above that. The trick that we were taught in residency was if you can dissect from the top down and you don't see the nerve, you can take a right angle clamp and just feel around a little bit. And if you can go up and put that in the sigmoid notch and you can say, I can see where my clamp is and I can feel that I haven't hit nerve and I don't see it below, then I'm above it. And
Yeah.
so I think that's a tidbit to avoiding some trouble and creating a little buffer for you.
Yeah, or just cutting underneath it. I mean, cutting underneath it
Yeah.
sounds crazy, but I
I
mean, as
mean,
long as you don't cut too far back, it should be fine. I mean, that's a whole school of thought to minimize the risk of nerve injury.
yeah,
So
is be inferior to the lingula. And then I mean I would throw out just what you're always we talk about a lot and you're big on is don't be married to your osteotomies being the same for every patient every time.
totally.
And look where the anatomy is, with CT being in everyone's office now, you can figure out where that nerve runs and you can modify your osteotomy to do your cuts in a safer place.
Yep.
Sometimes that might create other problems. You're doing a big advancement. You might want your Dalpont to be more anterior for segment overlap, other things, but you could do that. You're not a robot. You're not cutting the same thing every time. I think those would be little tidbits I would throw out there. You got any
Yep.
others?
I don't know. The one that I probably this is more of a conceptual one. It has to do with I think what you're going to start on, which is fixation. Because in the dental implant world, so have you correlated these two things yet? So in the dental implant world, if you got a patient where you put a dental implant in and then they have numbness afterwards, you got an X-ray, the best thing to do is to back the implant out, right? So to
Yeah, it looks like it's in close proximity.
yeah, because the management of injury and let's say inferior alveolar nerve injuries in dental implants and whatever first second molars um is that like you can over drill and have an injury to the nerve. We just kind of like forget about all that when it comes to orthognathic surgery because it's just there's so many other opportunities for nerve injury. But I do think there is I guess it would fall into the category of a witness nerve injury that you get an x-ray. And what do you think, that a screw's going through the nerve, or do
Man,
you don't
I think we've talked about this before, but it's been a while. I find that this is a completely different challenge. Like I think you're trying to
disagree? I
correlate
agree.
things that are maybe not that easily correlated because again, how much do you trust the position? Like, do you trust the CT to show you where the nerve actually is at that point?
In
Because
some places, I mean, I definitely agree that like within the mandible, right? Like within the mandible, especially if you freed up the nerve and that sort of thing, the nerve is going to sit in a different spot than where the radiographic canal
right,
would be, right? But let's say screws in the distal segment, right? Like screws compressing or maybe too long versus what would be needed. Is it wrong to think to open it up to take that screw out? I mean, is that honestly I haven't done it. I'm floating this as more of a concept and nerve injury, and I think I'd be
no, I
interested in
meon,
hearing people's
if
intake take on
if
this one.
if the
But
question is, do I think it's wrong? I would say no. If I do, I think it's needed. Here's where it gets tricky, and it's completely different than dental implants. Is with the dental implant patient, 2, 3, 4, 5, 6, 7 days later, you would not expect them to be numb without a
definitely,
problem.
yeah.
In a sagittal osteotomy, for them to be numb for 6 weeks would be normal, right?
Yeah.
Like you're like, okay, this is fine. So you don't know that you've caused a problem because
But
their symptomology is par for the course.
there's definitely times though in your post-operative imaging that give you more information there. Like there's a positional screw that you thought intraoperatively was going to one location and
Sure.
isn't in that location, right? Like it
But
just
don't you
has to
generally
do with the
feel, I
difficulty
mean,
of visualizing that thing.
it's probably not perfect and it's probably harder with the screw than the drill, but I feel like with the drill, I mean, I guess you could nick it, but like I feel like you kind of feel if you hit the nerve with the drill, I feel like you're
I'm
gonna
not
feel
I'm not
new.
saying that there's like an every time problem with fixation, but as someone who has seen a bunch of post-op jaw surgery x-rays, I've spent a lot of time looking at cone beams after that, and I see patients for revision. I have seen situations that it's at least very suspicious that the fixation is contributing to the numbness situation. And
Oh, no doubt.
the the time for that's early on. You want to let them heal. And it's like the philosophy of letting him heal. If there's a screw in the way, they're not going to heal.
Yeah, I mean,
I float the
I
idea
don't
of taking the
know.
screw out. And honestly, I'm saying this more as kind of like stirring up controversy to get so you can send me some emails. But I think this is an area that I don't think it's bad to take the screw out. So I think in a
No,
week, if you get an X-ray, I mean, otherwise the X-ray is just serving as a point of um, baseline to see how they recover from afterwards. But I mean, honestly, looking at critically evaluating your X-rays, and if it's I could see the situation where I would take someone back to take a screw out. Is what I'm getting at. Even though,
no, I'm with you. And I mean, I would say I've definitely seen orientation of my own screws and others where when I'm looking at it, I'm like, man, for the nerve to not be impacted by those screws, it would have to do like this pattern. And I'm like, what
yeah,
is the likelihood that that the nerve is actually going through that pattern? So I mean, I'm definitely with you where I see like, you know, you don't see the three screws at the superior border or two and then one below where it's like, look, there's a lot of space where that nerve could realistically be. And it's like one at superior border, one mid, and one inferior. And you're like, that nerve would have to have a pretty special pattern to dodge all three of those
Yeah, yeah.
screws.
Yeah,
I'm
and I think it's
100%
generally
with you on
positional
that.
screws. Yeah.
But yeah, I still don't know because again, even if it's within the confines of the bone, and I still think it could heal.
Yeah. All right. Nah, I mean, I don't know. I just
I
wanted
don't
to
know. You're just
controversial
trying to
opinion.
be controversial to be controversial.
Um, I think this is a good topic. I think there's a lot of uncertainty with this actually, like clarifying or improving the rates of numbness after sagittal osteotomy. I find this to be similar to treatments for TMJ disorders. Like it's there's so many different opportunities for nerve injury with sagittal osteotomy that it's almost hard to talk about it as a general topic. You know what I mean? Like I mean, just talking about witness nerve injuries as we've done today, there's enough variety to that topic. Whereas the injury to the nerve itself, I mean, compression and tension and partial injury, we didn't get into any of those things. I mean, we danced around them a little bit. And so, I mean, I think practicing in the world where obviously you're telling patients ahead of time that this is a real risk of the operation, but at the same time, doing everything you can to minimize that trouble. So I think it's worthwhile to repair it. I think it's something you'll encounter in practice, and having a strategy for it will help you out.
For sure. All right, you want to wrap it there? You got anything else?
Man, I don't have too much else. I think that's pretty good.
Yeah, you spoke enough,
We
really.
talking next week?
Hopefully, we'll figure it out. I'll
All right.
be out of town part of the week. All right, cool. Well, that was another Down Fracture podcast, a podcast for talking jaws. I think that's now 2 weeks in a row without an old man saying, so I don't feel good about that aspect of things.
You kind of had one in there. I mean, it wasn't like a really southern one, but I
Oh,
feel
like
like
the
it.
experience is what you get just right after you need it. Is that the one you're talking about?
Yeah, I think
That
that was
counts.
the one I was. Isn't that a
Count
saying?
probably.
So
I'm
I got counts. I'm counting it.
I'm probably butchering how it's actually said, but I mean I think we're keeping score. Let's score it. All right, cool. Well, that was another podcast. Thanks for listening. We appreciate any feedback. Downfracturepodcast@gmail.com. And here you'll see you next time.
All right. Catch you
All
later.
right. See ya.